Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health Center, reporting for the week of January 15th, 2024. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to keep you, your loved ones, and your community as safe as possible. COVID is still with us. It's still causing sickness, disability, and death, and there's still a lot we don't know. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Starting with wastewater, our earliest indicator of where we are with COVID, and this is from the National Wastewater Dashboard. So first off, nationally, the wastewater viral activity level for COVID is very high, and the region that has the highest wastewater viral activity is now the South. So you can see that this is actually the second highest we've been in terms of wastewater concentration of SARS-CoV-2 since they began reporting on wastewater. So it's second only to the Omicron wave, which is over to the far left in the winter of 2022. The shaded gray area to the far right is data from the most recent 2 weeks, which is usually incomplete, so it may change. So not sure if that little dip down is real or if it's going to go up. So this is something we will continue to keep an eye on. And now taking a look at weekly new hospital COVID admissions, these continue to climb. We are at 35,801 hospital admissions for the week ending January 6th. This is the 9th week in a row that COVID hospitalizations have just been increasing. And at over 35,000 hospital admissions in 1 week, that's about double where we were just this past November, about 2 months ago. And it is more than 5 times what it was just this past July. So definitely kind of hard to reconcile this reality with the "we have the tools and need to move on" message. Clearly, the tools or accessing those tools is not proving sufficient to prevent this level of suffering. And likewise, when we take a look at deaths, here we are looking at the week ending December 16th, when we had at least 1,653 deaths in the United States from COVID. And actually, that was the 3rd week in a row where we have had 1,600 deaths or more per week. And again, this is more than triple where we were for most of the month of July, when we got down to around 500 deaths per week. And with hospitalizations still heading up, unfortunately, we would expect this to keep on increasing. So here I will give my weekly reminder that many of these deaths could have been prevented. First off, by doing what we can do to prevent the spread of SARS-CoV-2. Also by being up to date on vaccination, and lastly, by accessing outpatient treatment as soon as possible after testing positive for those who should be treated. And if you should be treated, if you get COVID, you should know that now. Don't wait until you get sick to see how you'll do. That is not how this works. That's how you end up being too late and heading into that next phase of COVID that can result in hospitalization and death, when instead we could nip it in the bud if we stay prepared and act quickly. And just taking a look at COVID deaths in this past week by state, this is showing the percentage of deaths due to COVID for the week ending January 11th, so a little more updated, with the warmer colors indicating a higher percentage of deaths. And we can see that this is quite variable, but taking a look at Kentucky, 9.6 of all of the deaths in the state of Kentucky last week were due to COVID. So that is quite significant, and that is followed by Oklahoma at 6.2% of their deaths being due to COVID for the week ending January 11th. Now taking a look at influenza in the US for the week ending January 6th, and we're now at 14% positive tests for influenza. This is down from 17.5 the week prior. And when we look at positive tests on the graph on the left, it looks like we're coming down, and it would not be unusual for our peak to be around this time of year. Doesn't mean it will be the only peak, but it could be. Sometimes it can go down and come back up, but hopefully not. We'll just continue to keep an eye on that. And the week ending January 6th, there were over 18,000 patients admitted to the hospital with influenza. It was around 20,000 the week prior, so that's also a good sign, seeing the hospitalizations coming down. So far this flu season, there have been an estimated 150,000 hospitalizations, 9,400 deaths from flu so far this season, and 40 of those were pediatric deaths. And taking a look at RSV nationwide, that is still seeming to head up. We had some weird blip that happened there, but nonetheless, at the moment, it does seem to still be heading up, and there is quite a bit of RSV going around. Taking a look at COVID variant proportions, not much to add here since this hasn't been updated since last week. JN.1 is dominant at this point, over 61% of our specimens. It's highly mutated, very contagious, but so far our vaccines and treatments continue to work well enough against JN.1 and all the other variants so far. So for those paying attention, we've seen a shift in the headlines from talking about COVID to kind of lumping together all respiratory viruses. So wanted to unpack that a little bit. And I think there's a sense from some health communications folks that people are just tired of hearing about COVID, and it might go over better if we kind of lump it all together in there with flu and RSV and just call it respiratory viruses. And maybe they have a point, maybe not. But I think our purpose here on the People's Health Briefing is to make sure that the actual information is not getting lost. So I think outside of sort of the messaging considerations, one important reason that these viruses are getting lumped together right now during these winter months in the US is that these are the months, as we know, that generally encompass flu and RSV season. And even though flu and RSV can certainly start picking up earlier in the fall and may not leave us until, spring, the peaks are generally in the winter time. So during the winter time, we're used to seeing more colds and flus. And so it might make sense to talk about these things together because you catch them the same way, respiratory transmitted viruses. They present with overlapping symptoms. You generally don't know which is which until you test. And collectively, they can place a strain on the healthcare system, outpatient, inpatient, ICU, etc. So I can kind of get why it may be more convenient and sometimes more appropriate to lump these things together in discussion as respiratory viruses. But there are a couple of things I want to point out about this. First off, as we know, SARS-CoV-2 is not seasonal. It's not seasonal. So after respiratory virus season is behind us, maybe another month or two, SARS-CoV-2 will still be circulating and still be a threat. So at that point, it would not be appropriate to then just stop talking about respiratory illnesses just because two of them have decreased. Actually, in springtime, we often see an uptick of human metapneumovirus, and I don't think it really serves us to call springtime respiratory virus season just because of that. So the first point is COVID is year-round. It has peaks in every season. It's had peaks in every season so far. We seem to be seeing somewhat of a pattern in that our wintertime usually has our biggest surge, followed by a peak in the summertime. But let's face it, even our wintertime peaks and our summertime peaks have occurred in all different months of those seasons. And we've certainly had peaks in spring and fall as well. So when we talk about respiratory virus season, what we're really talking about in the US is wintertime, and we're really talking in terms of our healthcare systems. We're talking in terms of the overall burden to the healthcare systems and whether we'll have enough hospital capacity, enough hospital beds, and whether or not we'll have enough staff who are well enough to take care of patients. And of course, these are all very real concerns. So it is important that we're thinking about strain on our hospital systems and that we're thinking about the collective burden of all the respiratory illnesses in this way. But, and the second thing I want to say about this does not mean that you should be lumping them all together on the individual level. So system level, maybe, individual level, no. And what do I mean by that? Well, even though it is true that these respiratory transmitted viruses often have overlapping symptoms when you first catch them, there are actually very significant differences that should not be overlooked. So before we get to those differences, let's just take a look at how these three viruses are showing up this winter season. So first I wanted to share this January 12th report, and the link is in the post, and it is titled CDC Tracks Hospital Capacity as Respiratory Diseases Continue to Spread. And it goes through several important topics, including strain on hospitals and tracking hospital capacity. And the part I wanted to share with you here, because it's relevant to our topic, is this section called COVID-19 has changed respiratory disease season. And it talks about how COVID has changed respiratory illness patterns and how this has evolved over the pandemic so far. And I just wanted to bring to your attention the highlighted statement that COVID-19 continues to cause a larger number of hospitalizations and has been involved in many more deaths than flu and RSV combined. More deaths than flu and RSV combined. This continues to consistently be the case. So once again, we don't want to get confused in thinking that COVID is just a cold or a flu. One is clearly responsible for more hospitalizations and more deaths. And this is the case year round, and it's the case even in the peak of flu and RSV seasons. So now I wanted to share COVID, flu, and RSV hospitalization rates. And this is basically showing us this respiratory virus season, which is all those peaks on the far right, and last respiratory virus season, which are the peaks on the left. So those are winter of 22, 23. And the scales are a bit different between the two graphs. So the top graph is showing COVID and flu, and the bottom graph is showing RSV. But the RSV numbers are actually quite a bit smaller, so the scale is smaller. And so that RSV peak on the lower graph, which is on the purple line there, the highest it ever got was 5 per 100,000. Whereas if you look at the top graph, which is showing COVID influenza, the highest influenza peak there was last winter at 8 per 100,000, and COVID at 13 or so per 100,000. So COVID has essentially been higher, causing more hospitalizations than flu and RSV combined pretty much all year round. And another thing I wanted to point out is when you look at flu, the blue line, and RSV, the purple line, you can see that they go down practically pretty much to zero for actually most of the year. So there's a long period of time throughout the year, every year, where those two viruses are really not giving us any trouble at all, whereas COVID is causing hospitalizations at all times. It never goes down to zero. And the peaks are all over the place. You see a peak in late December, early January, another one in September, and then we're, of course, in the middle of one now. So once again, underscoring the point. And when we look at deaths from these three viruses, this chart makes it very plain. COVID deaths are in the orange, influenza deaths are in blue, RSV deaths are in purple. So yes, there are times of the year in the winter time in the US, or what we're calling respiratory virus season, where we are seeing all three viruses giving us trouble. But even then, COVID is causing far more deaths than influenza and RSV combined. And that is the case every single week of the year, even at the peaks of RSV and flu, even in so-called respiratory virus season. So now I think it's quite clear that the burden of COVID pretty much dwarfs that of flu and RSV, looking at all of the indicators, even right now when we supposedly feel like we have a better handle on COVID. So on an individual level, if you get sick with a respiratory virus, What's the difference? So, starting with the basics, how these viruses infect humans is very different and helps give us an indication as to why flu and RSV really are our respiratory infections, while COVID routinely affects multiple other systems in the body. And the way the viruses infect humans is very different. Flu and RSV both bind to epithelial cells. So those are the cells that kind of line the nasal passages and the respiratory tract. And so those respiratory viruses kind of attack there and go from there. And so typically, all we have is a respiratory type of an illness. COVID, on the other hand, as we'll remember, binds to our ACE2 receptors or our angiotensin converting enzyme 2 receptors, which are on multiple organ systems throughout the body. They're on not only the lungs, they're on the heart and the kidney and the liver and the intestines and the brain and so on. So those receptors are everywhere. And as a result, when that virus really gets to replicating, it can pretty much attack any and all organ systems. And we've definitely seen that happening. Another very bothersome thing about COVID is the fact that it takes longer to show symptoms. So there's a lot of transmission that's happening before the person even knows they're sick. With RSV and flu, it is possible to be contagious maybe a day before symptoms start, but for the most part, you are really most contagious when you have symptoms with flu and RSV. So typically, you get sick, then you're most contagious. So by then, hopefully, you're doing the right thing, you're isolating. Unfortunately, with COVID, there can be many days before a person gets symptoms where they're contagious. COVID can be spread by people before they show any symptoms at all, by people with very, very mild symptoms, and even by people who never experience any symptoms at all. And so that's called asymptomatic transmission. So no symptoms, but you still transmit. And on top of that, COVID is much, much more contagious. So one person with COVID is more likely to spread it to several people, and then those people then spread it to more people. So it creates these chains of transmission. Whereas with flu or RSV, it's typically much less. You typically hear one, maybe two, three at the most that get it from one index case or the original person that gets the infection. Whereas COVID, as we know, can cause entire super spreader events and then multiple chains of transmission from there. We're still seeing outbreaks like that with COVID. Another big difference is reinfection. How often can you get it? It's very unusual to get flu or RSV twice in 1 year. We almost never really hear of that unless you actually travel to different areas and maybe get a different strain. But most people get flu or RSV maybe once every few years or so. With COVID, it is not clear how many times you can get it, but there doesn't seem to be any limit at this point. People are getting it many times a year, and it doesn't seem like there is a limit. And lastly, I'll mention the outcomes and complications with COVID. Severe illness that can result in hospitalization or death has occurred even in healthy people, and it's still occurring even in healthy people. With flu and RSV, it's really those at the extremes of age, so little babies and elders, and then those with underlying conditions where we worry about a bad outcome. Definitely not impossible. It's just very rare for, let's say, a healthy 30, 40, 50-year-old to be hospitalized and die from flu. But unfortunately, we really can't say the same for COVID. Also, some people that get COVID, even if it's mild, can later develop multisystem inflammatory syndrome, MIS. Adults can get that. Children can get it. It can be quite devastating and severe, where, as the name indicates, any and all organs can be affected. People often have to go to the ICU, and it can be quite severe, even when the original COVID infection was mild. And other post-COVID complications include blood clots in the veins and the arteries of the lungs or the heart or the legs or the brain, new onset diabetes. These are just not things that we see after the flu or RSV. And lastly, anyone who gets COVID, even if it was mild, can end up with long COVID or symptoms that persist and can be disabling. And even though there can be post-viral syndromes that can occur with other viruses and even after flu, it is nowhere near as frequent, as severe, or as long lasting as long COVID. And because of the sheer number of infections that we're seeing with COVID, we are certainly experiencing quite a large burden of long COVID impacts on our population. So those are just some of the differences. I did a very deep dive with some studies in the May briefing. I've linked a couple of those studies in the post here in case you want to revisit those. But one question is, well, if I've already been infected, coughing, sore throat, etc., what difference does it make which one I got? Why should I care? So why should you care if it's COVID? So first off is, of course, timely treatment if it's indicated. As I said, if you're someone who should get treated for COVID, you should know that now. And you really want to start treatment as soon as possible. Like if you can start it immediately after your positive test, that is your best bet because the sooner you start it, you're interrupting that virus from replicating and getting you sicker, and it can completely change the trajectory or the course of your illness and can prevent you from going to the hospital or even dying. Secondly, isolation. I mentioned that COVID is a lot more contagious. Now, of course, I want you to stay home if you're sick, no matter what you have. And if you have respiratory illness, I don't want you to spread it to others at your workplace, at school, or in your household. So I linked the short video that we did about not spreading within your household, particularly not spreading COVID. I think the advice is similar for not spreading other respiratory illnesses, but essentially we don't want you to harm others. So we rather, if you stay home, isolate, try not to spread it to your family members, your household members. Definitely don't go around others, especially those who are vulnerable, but then we don't know who's vulnerable by just looking at them. So we should just assume everybody is, and we should just assume that we should not be spreading our germs to other people. So stay home, rest, isolate. And if you have COVID, this is particularly important because of what I've mentioned about how contagious it is. Third is contact notification. I mentioned that long period where before you get symptoms, you could be spreading it to others. So with COVID, you're going to want to go back 3, 4, 5 days before you found out you had COVID. Think about who you were around without a mask on and give them a call. Let them know. Give them the opportunity to get themselves tested and get themselves treated if that's what they need to do, is really the right thing to do. With flu and RSV, I think it's perfectly reasonable to call people you saw maybe the day before you got sick. Probably don't have to go back quite as far. Knowledge and documentation, and this is really for COVID. So, unfortunately, if you end up with long COVID or post COVID issues, first off, you want to know that's what you're dealing with. So, having symptoms and having it be a bit of a mystery as to what you had, it's not the best feeling. And I think, of course, knowledge is power, and you want to know what it is you had. But also, you may need documentation in the unfortunate instance that maybe you need some sick type of benefits or some type of disability benefits or something like that. So having that documentation is important as well. And last but not least would be your booster plan. So if it is COVID, that could impact when you may be considering getting a booster, whereas obviously if it's flu or RSV, it doesn't affect that at all. So if you got COVID, you may wait 2 to 3 months before you'd be worried about getting a booster or an updated vaccine. And remember that if you're using antigen tests at home to test, you really need 2 to 3 negative tests, spaced a day or two apart before you could really say that you don't have COVID. None of these tests are perfect, but definitely one negative test is not enough. Another option is to get tested by your healthcare provider, especially if you're someone who will be treated if you have COVID or flu, because remember, we also have antivirals for flu. So remember, with antivirals, the sooner you start with them, the better. It's true for flu. It's especially true for COVID. We want to interrupt these viruses from replicating in your body to reduce the chances that you get very sick. So we want to start right away. So if your healthcare provider can just do one swab, they can send it off for all three things and find out what you actually have so that you can be treated accordingly. But if that is not an option, then the home test can also be used. But remember, you can test after you have symptoms, but then if it's negative, you really do need to repeat it at least one or two more times. So 3 negative tests, a couple of days apart. And I think then you can say it's probably not COVID, but one time, no. And remember, you really got to take a good specimen. So most people are saying take a throat swab first, then a nasal swab. Although the official guidelines are continuing not to include the throat, but this is something that is recommended in other countries, so just something to be aware of. And if you do test positive, please test negative before you go back around other people. Do an antigen test to exit isolation. In general, we believe that enough virus to detect is enough to infect. And also, please don't push yourself. Allow yourself the time you need to fully recover. And remember, we want to avoid reinfection because remember, there doesn't seem to be an upper limit of how many times you can get COVID. And following COVID, we're seeing increased risk of impact on almost any organ system. We're seeing new onset diabetes, blood clots, heart attacks, strokes, memory issues, worsening asthma. And this could happen after your first infection, but maybe not until the second or the third. So catching COVID once and doing fine is not a guarantee about the next time. And every infection is a new opportunity, perhaps even a compounded opportunity for long COVID and post-COVID impacts. So let's keep up those best practices to prevent the spread of respiratory illnesses, especially to prevent COVID and long COVID. We're going to stay up to date on those vaccines, use a high quality filtration mask indoors like an N95, KN95, or KF94. Gather outside whenever you can. If you're indoors, really pay attention to that ventilation. That could be just opening some doors and some windows. Also making sure you have the appropriate filtration going on, like HEPA filters, and you can monitor that indoor quality with the CO2 monitor. Also, just limit the time that you're mixing indoors with people who might be positive. And of course, washing your hands is always a good practice to prevent the spread of a whole host of things, including norovirus, which we're also seeing some of. But also, let's remember to eat a balanced, nutritious diet, avoid those processed foods and sugary drinks. Let's get some regular physical activity, unless, of course, you're not feeling well. In that case, please get your rest. Remember, if you do not have a primary care provider, please get one and visit them. Get your blood pressure checked, your baseline labs checked, like sugar and cholesterol. Manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.